The Discussion of Awareness During Anesthesia by Meg Fleischle. Intraoperative awareness is the unexpected and explicit recall by patients of events that occurred during anesthesia. More than 40 million patients receive anesthesia each year. However, approximately 1 or 2 in every 1,000 patients who receive general anesthesia experience some degree of intraoperative awareness. Most patients do not experience pain, but rather have a vague recall of auditory events or dreaming. Approximately 36% of those who experience recall report some degree of pain, which is occasionally severe. Preventative strategies include monitoring by a skilled anesthesiologist and possibly the use of benzodiazepines to induce amnesia in high-risk patients. However, the latter should be determined on a case-by-case basis. The Practice Advisory for Intraoperative Awareness identified several patient characteristics and surgical factors that are common among high-risk patients. Some patient characteristics include age and limited cardiovascular reserves, which are the reserve mechanisms in the heart that compensate for defects which could make the heart's pumping action ineffective. Some reserve mechanisms include hypertrophy, enlargement, increase in heart rate, and an increase in stroke volume, as a result of the increase in muscle mass and enlargement of the ventricles. Other factors include drug resistance, substance abuse, intubation history, and previous episodes of intraoperative awareness. Some surgical factors include cesarean section, cardiac surgery, trauma surgery, and procedures involving muscle relaxants. A few possible causes for intraoperative awareness include unexpected patient-specific variability in dose requirements, the inability for a patient to tolerate sufficient doses of anesthesia, especially if he or she uses drugs or is currently taking other medications, the masking of beta blockers or a pacemaker, and the chance of potential equipment malfunction or misuse. This figure explains the basic effects of anesthetics on neurotransmission in the brain. Panel A looks at the effects on the GABA-A receptor, a pentameric ion channel identified by the 5 subunits that make up its structure. When the neurotransmitter GABA, as seen by the small red ball, binds to the GABA-A receptor, a conformational change in the receptor occurs. The channel pore opens, allowing a flux of chloride ions to cross the cell membrane, as seen by the small blue balls. Many general anesthetics, including barbiturates and benzodiazepines, increase the potency of GABA, thereby increasing the magnitude of chloride flux. This causes membrane hyperpolarization and a consequent reduction in the excitability of neurons. Therefore, general anesthetics, as seen by the yellow triangle, act as GABA agonists. Panel B looks at learning and memory in the hippocampus during anesthesia. Normal function in these structures depends on a delicate balance between excitatory and inhibitory neurotransmission. Synaptic GABA-A receptors are the primary mediators of inhibitory neurotransmission. Extrasynaptic GABA-A receptors are also present, have a unique subunit composition, and are particularly sensitive to modulation by general anesthetics. Sustained inhibition, via enhanced activation of these extrasynaptic receptors, may contribute to the memory-blocking properties of anesthetics. Awareness is the inability to accurately measure the depth of anesthesia. Some monitoring devices used to trace levels of awareness in patients include EEGs, responses to auditory stimuli such as a verbal command to lift an arm or leg, and electromyography, which monitors the electrical activity of muscles. An experiment conducted by Manuel Rojas, Gina Navas, Stephen Green, and David Rector looked at the discrimination of auditory stimuli during isoflurane anesthesia. Their work was published in CompMed in October of 2008. Previous work by Rojas and others have shown that late evoked burst responses synchronize to external stimuli, which might represent unconscious sensory processing. Since external stimuli during isoflurane anesthesia can initiate cortical burst activity, Rojas and his colleagues investigated whether context-specific cortical activity could occur during this state. Deep isoflurane anesthesia initiates a burst suppression pattern, otherwise known as BSP, in which high amplitude bursts are preceded by periods of nearly silent electroencephalogram. The burst suppression ratio, otherwise stated as BSR, is the percentage of suppression, as seen by the silent electroencephalogram, during the burst suppression pattern. Silent periods were induced by the anesthetic isoflurane. Further, they noted that cortical neural networks have patterns of spontaneous intrinsic activity in the absence of sensory input. In this experiment, Rojas and colleagues recorded the EEG continuously in isoflurane anesthetized Sprague Dawley rats while applying different types of external auditory stimulation. Screw electrodes were surgically implanted into the rats under ketamine xylazine anesthesia to record parietal and frontal EEGs. A reference electrode was placed over the occipital lobe. 2 wire electrodes were placed over the thoracic cavity to record the electromyogram. To generate familiarity with voices, rats were movement restrained by a female trainer who spoke to the rats in daily 2-hour sessions, starting 3 months before the surgical procedures and continuing for at least 2 months after, until the animals would remain calm in the restraint for at least 2 hours. During the recording sessions, movement-restrained animals were connected to an EEG amplifier and anesthetized using 5% isoflurane in oxygen. Once the EEG showed burst suppression patterns, the anesthetic gas was reduced to 2.3% isoflurane in oxygen. To achieve consistent burst suppression patterns with a similar level of surgical anesthesia in all animals, the experimenters applied a negative toe pinch test. To measure the effect of different isoflurane anesthesia levels on the burst suppression rate, animals were subject to 4 different isoflurane levels: 1.5%, 2.0%, 2.3%, and 3.0%. The 4 stimulation paradigms were as follows. 1. A familiar voice, like the female trainer, repeating some of the same words used during training. 2. An unfamiliar voice, either male or female, repeating similar words. 3. A 0.2 millisecond single click, which was generated by an earphone. And 4. Clapping at 1-second intervals. A single toe pinch test was applied during each of the different auditory stimulation paradigms to ensure that motor output was negative during the entire test. They also tested the effect of a painful stimulus on the burst suppression ratio by applying a toe pinch test. The toe pinch test consisted of an intermittent pinch, 1 second in duration, in 1-second intervals, with a total of 10 to 20 pinches applied to each rat. To produce consistent pinches, the same experimenter performed the toe pinch tests for all animals. Earlier studies, as well as their present study, showed that the burst suppression ratio increased as isoflurane doses increased. The data is not shown in this article. In the present study, Rojas and colleagues found that rapid decreases in the burst suppression ratio occurred during external stimulation under constant isoflurane concentration. Cortical burst activity increased during all types of stimulation, and consequently, the burst suppression ratio varied depending on the type of auditory stimulation applied. Here are examples of the EEG traces recorded during isoflurane anesthesia, during 2.3% isoflurane in oxygen. We can see that burst suppression patterns are different when different auditory stimulation paradigms and the painful toe pinch test are applied. The numbers on the right are the calculated burst suppression ratio for each sample. In general, we can see that the cortical burst activity increased when stimulation was applied. Therefore, the burst suppression ratio is lower in the presence of applied auditory stimulation than in the absence of stimulation. It is important to note that the familiar and unfamiliar voices generated differential burst suppression patterns and consequent burst suppression ratios. Also, clapping produced the strongest effect on the bass suppression pattern. Here is a bar graph showing the effect of external stimulation on cortical burst suppression. As noted in the EEG recording, the familiar female voice, as well as the clapping, produced the 2 lowest burst suppression ratios. Again, These results suggest discrimination of the external stimulation during deep isoflurane anesthesia, which again is 2.3% isoflurane and oxygen. In conclusion, the burst suppression pattern and burst suppression ratios are influenced by external stimulation. In addition, the burst suppression ratio can be manipulated differentially, with external stimulation depending on the type of stimulation, indicating that there are context-specific differences affecting the base suppression ratio. In general, these results suggest that there is some form of sensory processing and discrimination that can occur during isoflurane anesthesia. Therefore, monitoring the burst suppression ratio may be a beneficial technique in the operating room when determining the presence of intraoperative awareness in patients given general anesthesia.